Good afternoon, everyone, and thank you for spending this Saturday with us. I hope it's been at least half as inspiring and educational for you as it has been for me. So heartfelt congrats to Dr. Bond and the Dignity Health team. Now, as you can see from my opening slide, my name is Biljana Parapid. I'm an assistant professor of medicine cardiology at my hometown, Belgrade University School of Medicine, but also honorary W. Proctor Harvey teaching professor at Georgetown University School of Medicine, which is my second alma mater. And without further ado, I have no conflict of interest pertaining to the CME accredited talk, besides the fact that I happen to be a woman, a cardiologist, and treating women for over 15 years now. So if we look at the history of diabetes, the first lines written were in the Egyptian Ebers papyrus dating back to 1550, and the BC is not before COVID, as some people joke around lately. But while the term itself was coined by the Greek scholar Demetrius of Apamea, it was long disputed whether it was him or Apollonius of Memphis or Arethaeus of Cappadocia, although 2 centuries between them exist, so highly unlikely. The dual role of pancreas was actually confirmed by a French surgeon who did a 2-step pancreatectomy in dogs back in 1893 at the University of Montpellier in southern France, which happens the oldest actually European medical school that was started in 12th century. So he linked developing of frank diabetes to previously described Langerhans group of cells whose precise role was unknown at his lifetime. The importance of diet and exercise started at the dawn of the 20th century when during Franco-Prussian wars, a French doctor realized wartime food shortages improved outcomes, as we would say in modern medical English today. But the first book, An Adequate Diet and Exercise, appeared only in 1916 by the Elliot Jocelyn, whom I never fail to mention because our own medical school dean and my main diabetology mentor ever since I graduated from medical school happens to be Harvard Joslin Central alumnus. What you all know, that is Frederick Banting and Charles Best co-discovered insulin in 20th century, of course, but many may have missed the detail that the United Nations proclamation of World Diabetes Day being November 14 is actually Sir Frederick Banting's birthday. And at last, everything we have today as optimal medical treatment options was discovered basically between 1956 and 2015. Still, as International Diabetes Federation shows us with their 2019 estimates, 1 in 11 adults has diabetes, which is almost 500 million people on this planet. To that, 232 million remain undiagnosed, which is basically 1 in 2 people on Earth, and another 374 million people have impaired glucose tolerance that, if left untreated, will progress to diabetes. Which is even more concerning is that 84% of the 20 million children who come from hyperglycemia burdened pregnancies actually had mothers diagnosed with gestational diabetes. But let's zoom closer to home. And when we look at the data for North America and the Caribbean, it's not a pretty sight. We have 1 in 8 adults in the United States having diabetes, and sadly, the United States are the global IDF leaders in IGT, with 1 in 6 adults having impaired glucose tolerance, and second by number of children and adolescents with type 1 diabetes. When we look more predictions for 2030 and 2045, we can see actually a progressive growth where almost all those with IGT turn diabetic. The sex distribution is not encouraging either. As we can see, women follow. And sadly, 1 out of 4 live births are outcomes of hyperglycemia burden pregnancies. So with 38% of people undiagnosed in the United States and 1 in 2 having type 2 diabetes, there is still work to be done. But let's not forget that we're in the beautiful state of Arizona today. I was there for the first, and I hope not the last time, for AHA Epi Lifestyle, just as COVID was surging globally. And I would be more than happy that next year we do this live and not just live on internet. But sadly, as we can see, 10% of Arizona's adult population has diabetes, which is a bit over 500,000 people. And although 37,000 people are diagnosed with diabetes every year, there's still 146,000 wandering around in blissed ignorance that they actually do have diabetes. And finally, 35% of Arizona's adult population has pre-diabetes already. And these data are actually presented by ADA, but CDC ones from basically just February 2020. Now, the definition of diabetes is still very simple. We have type 1, which is caused by autoimmune beta cell destruction. We have specific forms with MODY and cystic fibrosis and pancreatitis-induced diabetes or post-transplant-induced diabetes with corticosteroids. And for these two, sadly, we don't have primordial or primary prevention measures to help out. But with which we do is the gestational diabetes that is diagnosed in the 2nd and 3rd trimester of a pregnancy that was a normal pregnancy till then, and the type 2 diabetic patients who actually develop progressive beta cell insulin secretion loss. The cutoffs, which I am sharing here in milligrams per deciliter, which are the measurements used in the United States, are the ADA ones, and they are valid actually for all types of diabetes. Now, you all know very well the micro and macrovascular complications, micro with retinopathy, nephropathy, neuropathy, stroke being increased double, MI doubled, also heart failure with a 2.5-fold risk, and peripheral arterial disease with 70% of all over 70 who have diabetes have it. But we very often forget about the fact that women suffer even more. They suffer more blindness, they suffer more depression. Their heart disease risk is not 2-fold, it's 4-fold and up. And through their life cycle, they battle with dysmenorrhea, dyspareunia, and eventually when they do get pregnant, they have more preeclampsia and more C-sections than non-diabetic women. And when they reach menopause, it creates an additional challenge due to new hormonal changes in achieving adequate glycoregulation. But still, as I have said, we have a decent amount of solutions. We just have to use them. Now, starting with sulfonylurea's appearance in 1956, the metformin introduction in 1959 outside the US and nationwide since 1990, which sadly got the support for UKPDS only in 1998. The TZD's appearance in 1996 was actually outshadowed by the FDA black box in 2007. And in 2008, we had a moment where FDA mandated that each novel drug in diabetes has to have a cardiovascular outcomes trial supporting it. So DPP-4Is, fortunately, got the approval in 2012, but only with a series of non-inferiority trials was fortunately that was enough for FDA to make them function on the market. So finally, we got the first CVOT trial approval for both GLP-1RA and SGLT2I together in 2015. Although GLP-1RA existed on the market from 2005 and SGLT2Is since 2013. I sincerely hope that the safety cap of prescription bottle drugs will not remain closed and that we will actually have more in the future. Now, I hate busy slides, but I still had to share with you something that I found in a relatively old paper. That's a paper from 2016, but actually it depicts very nicely the mechanism of function of SGLT2 inhibitors that function by increasing glucose reabsorption at renal level, and the GLP-RAs that have a multi-organ system function. Finally, when we look at their benefits, they share three important things for us. That is always lowering HbA1c, lowering BMI, and lowering blood pressure. Where they differ in reducing MACE for GLP-1RA, and SGLT2Is decrease heart failure hospitalizations and renal failure. And with what we have just heard at AHA that just finished a couple of days ago, we have also good news for patients who have heart failure but don't have diabetes. So that's another window of opportunity for all our patients everywhere. So in view of all the CVOT trials that we have seen over the past 4 years, we have survived. Fortunately, so did our patients. This avalanche of guidelines, recommendations, consensus documents, special documents, but there are just 3 key messages that I need you to take home today. First one is that whichever national or international society that is dedicated to cardiovascular disease or diabetes you prefer, each and every one of them on both sides of the Atlantic will advocate for use of both GLP-1RAs and SGLT2Is in patients with high risk or established atherosclerotic cardiovascular disease. ADA 2020 prefers starting with metformin. I know you will say it's easy for me because I was also trained in diabetology, but let me reassure you that introducing metformin to someone is a wise, cost-effective, and pretty safe choice, because with just the initial dose of 500 milligrams once a day, preferably BID, you will actually help our endocrinologist colleagues once the patient makes it to their clinic in 4 to 6 weeks, because taking in consideration the percentage of availabilities for endocrinologists and the overall number of cardiologists over number of endocrinologists, it surely takes more than 6 weeks for any of our patients to make it to an endocrinology clinic, even if we call our med school buddy working in the same system. And the third message finally is that both ACC Diabetes Consensus from 2020 that appeared this spring and the previously mentioned ADA 2020 document from earlier this year actually advise to pick one new drug based on target. We know they reduce MACE, so now the question is only whether you want to enhance weight loss in your patients, and in that case you could opt for GLP-1RA, or you want to prevent new episodes of heart failure and slow down, hopefully, renal failure based on diabetic nephropathy in your patient. Still, this world, thank God for small favors, is full of colors. But sometimes when we read the results of our trials and when we read our guidelines, we somehow believe that all the trialists running the trials and all people sitting on all task forces and guideline committees seem to be actually oblivious of all the beauty of all these colors, because we don't actually see what we need to see in the guidelines and in our trials. It is very well known that African American, Hispanic Latino, American Indian or Alaska Native, and Asian Pacific Islander women suffer worse complications of diabetes than their Caucasian sisters. So we need to include them in the trials to be sure that actually these drugs do help them as well, because I love to quote, we actually all love to quote our Dr. Nanette Cass-Wenger, our global shero and mentor, who always used to say that women are not small men. And with that, I would just like to share with you one result of our group. It was a protocol designed by Dr. Annabelle Waldman, also an academic daughter of Dr. Wenger, and myself in the late winter of 2018 here in Belgrade, during actually the week following the first Dr. Nanette Cass-Wenger International Conference on Women's Health that announced the opening of the first Women's Heart Center in the region and third in Europe that will bear Dr. Wenger's name. It's going to physically open also this year. We delayed due to COVID. But the thing is, we even then, at that time, and it was a paper that was actually accepted and presented at ESC 2019 last year, we have shown that although women did benefit from SGLT2/1 at the time, we had only EMPA-REG and declared TIMI58. We have shown actually that women had a greater reduction of MACE, better one than men. It was still not statistically significant. So we have to continue advocating for more inclusion of adequate populations to all our trials everywhere. Finally, we know that fatal outcomes and quality of life issues are the issues of yesterday. Today, we are very privileged to have insulin pump, GDMT, and personalized approach. I'm deliberately omitting the issue of cost, because cost is something we all battle in all systems and all cultures in all four corners of the world. But we have to remember that tomorrow we have to be more diverse. We have to be more inclusive. Some say that future is female, but if the future is not fully female, it's not a problem. Let's just not forget about all those children that come from adverse pregnancy outcome pregnancies, whose mothers actually battled hypertension, diabetes, and everything that goes together, and we all know what happens with damaged endothelial when it's damaged. So let's help them have a better future. And once again, thank you, Dr. Bond and Dignity Health, for your invitation. And I look forward to questions you send us via the Q&A box or Twitter using the WHV Symposium 20 hashtag. Thank you.